Welcome to unRemarkable Labs. And this is going to be sort of a two-part. First, I'm going to have you figure out what labs you want to order, and then we'll figure out how to interpret the labs. And so this is a real case that is published, and I'm going to give you the short chief complaint, and it's a 41-year-old woman with confusion, and she's had a previous Roux-en-Y surgery. So job number one is let's come up with essentially a schema for someone who's had Roux-en-Y surgery and is confused, and all the things that you need to worry about. And I'll let Fernand and Anne-Marie, y'all decide how you want to do it. You can bounce off each other, whatever, however you want to do this.
So I think first of all, when approaching fusion, I try to approach it like I would any other patient kind of initially. Think about the things that would be rapidly reversible and that could be immediately life-threatening. So I'm going to be checking a glucose level, thinking about hypoglycemia. I'm going to be, depending on the clinical context, I'm thinking about, do I need to give Narcan? Could there be some sort of overdose or something else going on here? And then do I need to give some sort of like thiamine or something like that? So those are kind of like the first things I do is like kind of what things would I need to be doing immediately. And then I'm going to take some time to kind of work through working up the patient. So, you know, I have this background of Roux-en-Y gastric bypass. So it's like my mind is immediately going to certain things, but I still want to be systemic. So I'm going to be kind of going through metabolic, infectious, I'm like blanking on this right now. Structural, that's it, and toxins or toxin withdrawal. And so I'm going to want to kind of first know the context besides the Roux-en-Y gastric bypass. Who is my patient, and in what context am I seeing this patient? Is this in the emergency room, or is it in the PCP office, specialist office, or in the hospital? Because that's going to kind of change what's on the differential. I'm going to want to get, you know, after an examination, making sure the vital signs are stable and everything like that, you know, first stabilize. I'm going to want to like think about all the laboratory things. So metabolic, thinking about calcium, thinking about sodium, thinking about could there be some sort of CO2 retention? Could there be some sort of renal injury? Could there be some sort of metabolic cause, including adrenal? Thyroid, we already talked about hypoglycemia as well. And then I'm also going to be thinking about all the vitamins as well, especially with gastric bypass, thinking about thiamine, thinking about B12, thinking about copper, which you also have to think about in gastric bypass, which can mimic B12 deficiency. And then thinking about like things like anemia as well. And then, you know, kind of seeing, do I have any sort of infectious triggers? You know, that would, a lot of it would depend on the context in which you saw the patient. Thinking about kind of the low-hanging fruit, like urinary tract infection, bacteremia, pneumonia, biliary infection, skin infection are kind of the low-hanging fruit, but then also not wanting to miss a meningitis and encephalitis.
So Fernand, Anne-Marie gave us a great big overview. Why don't you take that and give me a list of labs that you think are going to be worthwhile. And I will give you this much information. The answer is related to the Roux-en-Y. So I love the way Anne-Marie discussed that. So the first thing we did was make sure the patient was stable. The patient was afebrile, had not had a fever for some time, had a normal finger stick in the ER, had a urine drug screen and was not on opiates, a variety of things like that. So Fernand, maybe you can I probably have most of the labs you're going to want, but why don't you go ahead and say, and if you want to expand on what Anne-Marie said, that'd be great too.
Yeah, I mean, I think Anne-Marie gave a pretty good overview. I don't know what's really left for me to comment on, but I still think I can find a few thoughts. I would like to highlight the fact that we have been trying to move away from the bariatric surgery tag. We have been talking about metabolic surgery and using this to treat metabolic syndrome, especially to induce hypertension and diabetes remission. Why am I stressing on that? Because this surgery basically leads to a lot of metabolic changes. If you want to use the word metabolic to kind of as an umbrella to include vitamins, to include your glucose metabolism, to include trace elements. So these are the main things that come to my mind. And I always have on my mind 4 different medications that or supplements that metabolic surgery patient should be on in general, depending on the type of surgery they had. Vitamin B12 supplementation, they should be on multivitamins, including trace elements, because some of the elements such as manganese, copper are elements that they need to be supplemented with because they do not get absorbed. They should be on iron supplementation because they lose some of the stomach and a big part of the duodenum and jejunum in some of the surgeries. So a lot of iron deficiency because of lack of absorption. And patients should be on vitamin D because they lack that. So if I look at these, vitamin D should not affect cognition as far as I know. Iron should not affect your mentation. It leads to IDA, which I deal with most of the time. And the others are very tricky. B12, severe B12 deficiency can cause neurohematologic syndrome of all sorts, including some subacute dementia. So that's on my list, and I would.
I'm gonna stop you right there because there's a very important teaching point here. As a hemonc fellow, we always think about B12 and pernicious anemia. We think about megaloblastic anemia. How often do you get neurological findings from B12 deficiency without hematological findings? I had to learn this because I actually had a couple of patients with this. And if you've noticed, neurologists order B12 levels regardless of the CBC. And it's because about 25% of patients with B12 deficiency just present with neurological findings. That's a really good number to keep in the back of your mind, and it sort of tells you to look for it even when you don't have megaloblastic anemia. And I'm not exactly sure why that occurs. The other thing that Dhruv just put in here is that there may be a move back to Roux-en-Y surgery because it looks like it has better outcomes than sleeve gastrostomy. There's a lot going on in the chat about sleeve gastrostomies becoming more popular, but I actually did a podcast and Dhruv put a link to it that some of the people who are trying to treat metabolic syndrome are moving towards Roux-en-Y, given all the side effects that we're talking about right now. And so it was more old school. And the case that we're presenting was published in 2013. And the patient had the Roux-en-Y quite a bit before that. But you may be seeing more of it because it seems like it does a better job. So B12, I think, is important regardless of the CBC.
B12 and I include with it methylmalonic acid because it takes a lot of time to come back. Sometimes you have a borderline B12 around 300, 400, and sometimes it with a high MMA, but sometimes your B12 is 200. You're assuming this is functional B12 deficiency, but it's not because the methylmalonic acid is not high. So I always do the couple together. Mm-hmm. The other thing I think, so copper is very important. So copper deficiency can happen if you do not absorb it, just like in metabolic surgery, and especially if you're overdosing on zinc, which is probably not the case in here. But with COVID-19 pandemic, a lot of people took a lot of zinc. So it's something to keep in mind. Copper deficiency literally mimics B12 deficiency. It can lead to an MDS-like syndrome with thrombocytopenia, leukopenia, some form of anemia, or a combination of these conditions, plus central nervous system syndrome that's more could be like an encephalitis, myelitis picture. So this is also something to keep in mind. The other trace elements, I cannot remember like specific ones that can cause altered mental status. I'm pretty sure you can find something out there. I'm not sure if like manganese deficiency can cause this. I'm not specifically sure. And I'm not sure about the levels, if you dose these levels in the body, how reliable they are. But I'm pretty sure it's very important to know about this. B vitamins are included in your multivitamin supplementation. Thiamine deficiency, definitely, if they are not absorbing it well, definitely can cause our full-blown Wernicke-Korsakoff syndrome, which can be subacute. It starts as a confusion syndrome. It progresses to a psychosis, which is the terminal Korsakoff psychosis. Especially if the patient drinks, if the patient doesn't eat well. So I think B3, not niacin, can cause pellagra, which is a form of diarrhea with changes in your mental status. B6, I'm not sure B6 can cause this. Folic acid should not cause neuro problems. I think this is what I think about in the B lines of vitamin. A, D, E, K. I just learned recently that overdosing of vitamin A and E can cause you to have a vitamin K deficiency. All of this should not cause you to have any brain problems, as far as I know. Vitamin A can cause visual problems, can cause I thought some autoimmune problems if you have deficiencies, if I'm not mistaken, but I'm not aware of any.
So the trace metals are probably related to an unusual complication of Roux-en-Y that can be fatal. It'll present with confusion and can be fatal.
Yeah.
Anne-Marie or Fernand, do you know what I'm talking about?
So is it dumping?
No, dumping is a different kind of syndrome.
Yeah,
Anne-Marie?
So a few other things I'd be worried about is high ammonia levels, I'm going to say, secondary to SIBO that you can get after Roux-en-Y gastric bypass. And then also thinking about you can get hypoglycemia, D-lactic acidosis as well. So those would be kind of the big things I'd be thinking about.
The weird one that I wanted y'all to know about is hyperammonemia, which is probably due to trace metal deficiencies. They did some studies, and it was not a form fruste of transcarbamylase deficiencies. If we want to go back to pediatrics, that's for Druve. And those seem to be related to trace metals and is actually pretty important. The hyperammonemia, it may be like the valproic acid, but you can certainly, we actually had some patients die at our hospitals a number of years ago. Giving them back trace metals seems to make a difference. And there's been some articles on that. So that's something to think about. They're talking about D-lactic acidosis, and you mentioned D-lactic acidosis. So let me just stop. Does everybody in the chat know what we're talking about when we're talking about Roux-en-Y surgery? So I think it's really important to make sure this is specific for Roux-en-Y surgery and not for sleeve gastrostomy. So does anybody not know what a Roux-en-Y surgery means? So I'm assuming, be brave.
Give us the refresher. I think the refresher is always good.
Yeah. So this is an end to side hookup of the jejunum to the gastric remnant, and so you get a blind loop, and you therefore, with that blind loop, can get bacterial overgrowth. You can also have a very, not related to this, but I actually saw a patient who had intussusception, Roux-en-Y's predisposed to intussusception. I saw a patient who came in with small bowel obstruction from intussusception, which if you read about it, Roux-en-Y's can cause. Okay, thank you for bringing that up. Really appreciate it, Travis.
Y'all see that?
Okay, so we know what surgery we're talking about. So we have a list of things. So let me tell you the story. This woman came in for the third episode of I Feel Drunk. And she had, in this case, a 12 to 14 hour history of confusion, some imbalance with walking and speech, and an alcohol level of 0. This had happened twice before, and she also had an unexplained metabolic acidosis at that time. She had chronic diarrhea at baseline, another complication of Roux-en-Y surgery. But her diarrhea had not gotten worse. She had a nutritional diet, no history of vision changes or recent change in medication. She had the bariatric surgery and a cholecystectomy 3 years before. She had postoperative supramesenteric artery thrombosis. So she had also had a partial resection of part of her small bowel. Her meds, in case somebody will write this down in the chat since we don't have a whiteboard. She's on 200 of spironolactone daily, 125 of loperamide as needed, 650 milligrams of sodium bicarbonate twice daily, 50 micrograms of levothyroxine daily, and 1 multivitamin a day. So when she presents, she's afebrile at 96.9, a regular pulse of 72, blood pressure of 115/84, a normal respiratory rate, and O2 sat of 100%. She was a thin woman in no acute distress. Her heart and lungs were normal. She had scars consistent with her procedures on her abdomen, but no other abnormalities. She had no rashes or obvious lesions. Her speech was slightly slurred, more obvious to the family than to the doctor. Her gait was minimally ataxic, but otherwise her numbers, her exam was okay. So here are the lab data. Drew, if you could write the labs down in the chat so everybody can see them, I'd appreciate it. Sodium 140, potassium 3.8, chloride 116, bicarbonate 9, BUN 5, creatinine 0.8. Okay, so you can put those down, and then I'll give you the other numbers that are important. Her glucose is 83. Her albumin's 2.3. Her copper is low normal at 74. Her zinc is low normal at 60. Her TSH is normal at 2.8. Her vitamin B12 is totally normal at 670. Her ammonia is 19, which is normal, and her thiamine is 7, which is a little bit low. So we have all those things that we predicted before, but obviously the acid-base disorders where I got excited, and where we don't have an ABG or a VBG. No, we do have an arterial blood gas. The arterial blood gas with a pH of 7.2, a PCO2 of 13, a PO2 of 138, and a calculated bicarb of 5. So let's go over the differential that we had before. The copper is on the low side and certainly needs to be repleted. The zinc is on the low side. Her zinc was 60, and that's the lower limits of normal. So that needs to be replaced. Her thiamine is a little bit on the low side, and that needs to be replaced. So this is a lady who really has a lot of problems. But what is interesting is to try to figure out what we can learn. The albumin was 2.5, I think. 2.5, not 2.3. So what's interesting is to try to figure out her acid-base disorder. So I'd like everybody to carefully go through the calculations and try to figure out what her acid-base disorder is. And then I'll tell you how I approached it. This was presented to me at Morning Report by one of our really excellent residents. And so this was a blind case for me 10 years ago. So I'll give everybody about a minute to think through the acid base, and whoever wants to volunteer a complete discussion of the acid base disorder, it'll be greatly appreciated. So Travis, you're 100% correct. We have to replace all the metals. We have to replace the thiamine. All those things put her at risk long-term, but they don't explain why she's confused right now. And they don't explain her acid-base disorder.
Hey, is there any difference between getting like an RBC thiamine and like a serum? I know like our lab kind of gives us options to do two different ones, but is there a purpose or a point of doing both of those, or does anyone?
I don't know that, but I remember that I learned at Virtual Morning Report that if you're not sure about the thiamine and you really suspect it and want to diagnose it, you can get a transketolase level is a better measure of whether there's really thiamine deficiency than the thiamine level itself. You can have thiamine deficiency with a normal thiamine level. So she may have had thiamine deficiency. I've never ordered transketolase because I know it would take 2 weeks to come back and I'd be off service. Okay, so Dhruv says this is a normal anion gap metabolic acidosis with incomplete respiratory compensation. Okay, so what should the anion, so let's work through this step by step. And you can look at the, you can scroll up and down the chat to look at the numbers. What should her anion gap be with an albumin of 2.5?
Oh, it should be 10 and her gap is 15. So it's
her anion gap should be something like 8 really. So the way we've always done at UAB is we just multiply the albumin times 3. That gets you within 1 or 2 of the actual formula. And so at 2.5, you'd expect it to be around an anion gap of 8. She has an anion gap of
15.
So she actually has a slightly increased anion gap. Mm-hmm. Now, what's interesting, this is one of the things that's interesting about this case, is that her anion gap normally, you know, if she had a normal albumin, that means her bicarb would have been 19. I mean, her anion gap would have been 19. And normally I wouldn't get excited about an anion gap of 19. I normally don't get excited about any anion gap below 25 because they usually resolve on their own. But it was different in this case because of one of the diagnoses that Fernand mentioned before. And we'll get to that here in a second. So if she should have a gap, she should have a gap of 8 and she has a gap of 15, so she has 7 excess. If we add 7 back, that difference, that delta gap, if we add that back to her bicarb, and we have to add that back to our observed bicarb of 9, she actually has a slightly increased anion gap and she has a normal gap acidosis. So this is where the delta gap allows you to have 2 different kinds of acidosis. Now, we sort of knew she had a normal gap acidosis because she's been treated with bicarb. But she was probably treated by either surgeons or gastroenterologists who don't understand how to give bicarb. How much bicarb was she getting? Anybody?
650 once a day.
Oh, 650 twice a day. And how many milliequivalents is that? Nobody ever remembers this. which is why I teach it over and over and over again. You cannot teach this so many times that people actually remember it. You can actually calculate it, and I'll do that. I can do it for you if you want me to. But if you know the molecular weight of sodium bicarb, so that's milligrams per milliequivalent. So if you divide that into the number of milligrams, you know how many milliequivalents you have. It's 7.7, or just think 7.5. So she's getting 15 milliequivalents of bicarb per day with enough diarrhea to cause a normal gap acidosis. That's actually not very much at all. So many of you have seen chronic kidney disease patients on bicarb supplementation now. And what I'm seeing all the time is 1,300 twice a day, which is 30 milliequivalents. And sometimes that's not enough. And sometimes I see it 3 times a day. So this is lesson number 1 that of the basics of acid base, is that if you're going to give bicarb, you have to give quite a bit. Now, what Joel Toft teaches is you can give half a teaspoon of sodium bicarb, and I think it's about 45 to 50 milliequivalents in a teaspoon of sodium bicarb, baking soda, Arm & Hammer baking soda. And so you can get about 20 to 25 milliequivalents from just half a teaspoon of baking soda per day. And that's a lot easier for patients to buy. It's a lot cheaper than buying sodium bicarb. Okay, so Travis, thanks for writing that down in the chat so that people can get back to that. So the teaspoon is actually 60 milliequivalents, so it's 30 milliequivalents. So it's cheaper and easier to use Arm & Hammer. So this patient was not getting very much sodium bicarb. We assumed, and we were diagnosing this patient's normal gap acidosis after we had already played around with the anion gap acidosis. Now, Fernand talked about D-lactic acidosis. So what is D-lactic acidosis, and why are we still worried about that in this case? You mentioned it, Fernand.
I think Travis did in the chat.
Okay. Well, then we'll let Travis talk about it. What's D-lactic acidosis, Travis?
Oh my goodness. Honestly, I know very little about D-lactic acidosis, and
Okay.
I pulled up an article to read about it. It's not really anything that I see a lot in the ER. I see the
have you ever
alcoholic
dealt with it,
ketoacidosis.
Anne-Marie?
I haven't dealt with it personally myself.
Okay, so it's really, really interesting. It turns out that bacteria metabolize carbohydrates and produce the isomer D-lactic acidosis. We measure L-lactic acidosis normally. And it turns out that if you have increased D-lactic acidosis, and if anybody really wants to nerd out, this great journal from Baltimore called Medicine. I'm sure you've looked up review articles in that. Has anybody looked up review articles in Medicine before?
Yes.
Highly recommended. Highly recommended. And in this case, they had a whole series of a lot of patients with D-lactic acidosis.
Is he frozen?
I think so.
Is Medicine a open access journal, Fernand?
Not sure. Use Sci-Hub.
What is that?
I'll send you the link.
Please.
You've got secret links, secret medical
does.
journals.
Yeah, I mean, I put until he hops back, I put a link.
Paste your PubMed link into this, and there's some magic.
Copying it right now. Nice. Yeah, I put a link to this article in Gastroenterology Research and Practice about D-lactic acidosis and encephalopathy, I guess until Uncle Bob comes back. But, I was looking to see about how it's measured because I know the lab actually doesn't measure lactic acid. I think it measures sodium lactate. Is that the same across everyone's labs? Because you're talking about, if you give someone lactated ringers, everyone gets worried about, the lactic acid being elevated if you're going to recheck, but there really isn't any evidence to support that. So actually what they're measuring in the lab for lactic acid.
I thought they were measuring L-lactate, and the D-lactate is a send-out. I've heard of people sending it out, but I'm not sure, honestly. I only read about D-lactic acidosis, never seen it.
Yeah, same. I mean, it's always the I've heard it, but the papers, but I've never like seen it diagnosed.
Yeah, I still have on my wish list pheochromocytoma, meningococcemia. Never seen these.
Interesting. I've already seen a few. And a
So
malignant one, and a malignant one at that.
So this basically says the blood work for this will reveal anion gap metabolic acidosis. If the delta-delta ratio is calculated, it'll range between 1 and 2 unless there's an additional contributing factor. The rise in the anion gap is less than expected. So kind of like he was saying, he doesn't really get excited with, an anion gap that really isn't that elevated, something less than 25, is something that likely will resolve on its own. So it kind of goes under the radar. So this is due to the specificity of D-lactate, which makes it easier for D rather than L to be excreted in the urine. So it can cause both an anion gap metabolic acidosis and a hyperchloremic metabolic acidosis. And I think that's what we have here too. The chloride is 113.
Mm-hmm.
So sometimes the urine anion gap may be positive. And this, both this and the hyperchloremic is he back in?
Power. He lost power.
Oh, nuts.
So the urine osmolar gap can be used to calculate unmeasured cations such as ammonium, which is excreted more in D-lactic acidosis due to systemic acidosis, help differentiating it from an RTA. So you're going to have to bust out the urine osmolar gap. Special assays are required to measure levels of D-lactate as these assays contain D-lactate dehydrogenase. During acute episodes, the levels can rise, and while there is no standard, a D-lactate concentration greater than 3 millimoles is used to define. So it sounds like it's a special lab to go to add on here. But that's all I have. I had that article here to learn about it. So I don't know if he's going to be able to hop back on and go over everything with a case. Does anyone have the case that we can pull up on PubMed here?
Ooh, that I don't know.
He said, please let everyone know I'm very sorry.
But listen, he lives in the area where there's tons of tornadoes and things like that. So
yeah. I think trying to download. I asked him if he can join on the phone. So I don't know if he has the application. So he's trying to download.
Yeah, because you can call in with less service than doing this.
Mm-hmm.
So anyways, I'm assuming this is it. So treatment for a D-lactic acidosis. So enteral carbohydrates should be avoided. And that will decrease the D-lactate due to lack of substrate, but also the lactate-producing bacteria will starve and die in the absence of a food source.
Mm-hmm.
So starve it. And then carbohydrates can be supplemented parentally. Thiamine supplementation should be considered to cover for the additional pyruvate dehydrogenase activity, especially in the cerebellum. Oral antibiotics that are poorly absorbed or more effectively used locally in the gut. These include Clinda, Vanc, neomycin, and kanamycin with a K, but I don't think anyone uses that. In rare cases, hemodialysis has been used to rapidly clear D-lactate from plasma.
I'm wondering if rifaximin can also be used.
I mean, I think in the hyperammonemia, if that was a case, probably.
Mm-hmm.
Yeah, Kushal, you know, I don't know too much about SIBO, but there was a couple tutorials that someone had put discussing it. So it's kind of a new thing to me. Patients with
I'm back.
hey,
Woo!
welcome. I was just reading some things on D-lactic acidosis.
Oh, great.
We were waiting for the you to come out of your bunker, your tornado bunker.
It
heard
wasn't
you.
a tornado. I mean, we just lose electricity, and it's. I told you that at the beginning. Okay, where was I, and what should I talk about?
Lactic acid.
Yeah.
So, the. Okay, so I lost the chat, but that's okay. So what happened is the resident who presented to me, who's now the head of our is the program director for the GI Fellowship, as a second year resident, knew about D-lactic acidosis, went back and talked to the patient, and in all 3 episodes, it had happened after she ate a meal of pasta.
Mm-hmm.
So what do you do? First of all, you make sure they don't eat pasta. So high carbohydrate meals is what stimulates it, because the bacteria break down the carbohydrates.
Can I make a joke?
Sure.
Was she using vodka sauce?
She was not, but I like it. I like it a lot. Thank you, Anne Marie. That's excellent. And that would be Dr. Bursky. That's correct. And I'll put the link in the chat for you of the article that we wrote up on this. He did give antibiotics at the time, may not have been necessary. And the patient did get better, still had all these other problems. And what was interesting is the first time we discussed it, we just discussed the D-lactic acidosis. But as you can see, this was all complicated by the fact that she had this diarrhea from short gut syndrome. And she also probably had a lot of other of these metabolic problems that Fernand so well and Anne-Marie so well described, that there are all kinds of things that were going on with her. The idea, the big idea here was to understand that while normally a small anion gap doesn't get us excited, in this one situation it did. And we actually had data to show that she normally didn't have this small anion gap. So I wanted to present it to make us think about people who have these GI procedures who come in altered. In this case, all the clues pointed towards this particular diagnosis. So Robert Weber says keto diet. You can get the same thing from keto diet, Robert? Unmute yourself and tell us about that. Hello, Robert Weber.
Sorry, I'm commuting. No, I was just gonna say this person could try the keto diet for a low carbohydrate option.
Yeah, she was okay until she actually because Chad Bursky was so smart, he figured out to ask about the high carbohydrate load, and then got reassurance that every time this happened, this was due to a high carbohydrate load. So as long as I don't think you'd have to go as far as a keto diet, but a low carb diet in general is going to be important for these people. But what I loved that Anne Marie and Fernand both demonstrated is it's just like looking at a chest x-ray. If you're concerned about heart failure, you look at the lungs and the bones and the abdomen and the diaphragm before you look at the lungs. And what they did so nicely is they said, okay, let's make sure it's not any of these other things. And I'm just trying to fool you with the history of bariatric surgery. before we focus on all the things that bariatric surgery occurs. So, Anne-Marie, you've done some research while I was in Never Neverland trying to get my internet back. Why don't you teach us about what you learned about altered mental status after gastric bypass? Because I love what you put in the chat.
Okay, when thinking about altered mental status after gastric bypass, kind of the first thing I'm going to be thinking about is this related to low glucose or not? And if it's hypoglycemia related, some of the things I'm going to be thinking about are dumping syndrome, so getting a really good clinical history. There's also this other etiology. I'm kind of scared to try to pronounce this. But basically, there was an RLR series on it where you get pancreatic hypertrophy of some of the islet cells, and then you can get increased insulin secretion from that after gastric bypass. Did anyone nestidoblastosis? And then also thinking about thiamine deficiency, presenting it as Wernicke's-Korsakoff, and then wet and dry beriberi, pellagra, as Fernand mentioned, B12 deficiency. And then when we think about B12, we're also going to think about copper deficiency, vitamin E deficiency, and then also thinking about things like short gut and the associated D-lactic acidosis, and then high ammonia levels as well would be kind of some of the things after gastric bypass I think about.
I think you just created a schema for us, Anne-Marie. That was beautiful. I think that's important. Let's reemphasize that the copper one. You will see copper deficiency. So somebody mentioned taking too much zinc. I think Fernand mentioned that. You know, the classic story is someone who's using too much zinc preparation with their artificial teeth and absorbing too much zinc and getting copper deficiency. But copper is a cofactor in B12 metabolism, I think. Is that right, Fernand?
Yes.
And so that's why, so copper deficiency mimics all of the problems of B12 deficiency. I think zinc deficiency, I think zinc is a cofactor for the transcarbamylase, ornithine transcarbamylase pathway. And I think that it has something to do with that and some other trace metals to do with the hyperammonemia. Because if you have disruption of ornithine transcarbamylase, we all learned that and we all forgot that. Drew has to know that because it's actually pretty important in pediatrics. This particular syndrome is an unusual one, but if the people that I was talking to in the podcast are right, and there is an increase in this metabolic surgery, and I love the way, I think it's really important the way that Fernand stressed that this is metabolic surgery as much as it is weight loss surgery, because you get all kinds of benefits, and the benefits do outweigh the decrease. Thiago mentioned, I think it was Thiago, were you the one who mentioned that y'all, somebody mentioned they had a clinic where they saw a lot of these people. Who mentioned that? I might have the wrong person mentioning it.
I think Rafa did.
Rafa did.
Mm-hmm.
So as an internist, it's easy for me to have a skewed view of the complications of bariatric surgery because they all get admitted to medicine. We don't see the successes. So unless you're taking care of a lot of people with a disease, especially a surgical disease, you overestimate the base rate of complications because you see all the complications and you don't see the people who are doing just fine. And so that's always a difficult thing. So do you see this, Rafa? You've been in that, have you been in that clinic? Can you talk about that for us?
Oh yeah, so here in my university we have like specialized outpatient service for patients post bariatric surgery. Most of them has like a lot of hernias and also a lot of anemia, a lot of nutrition deficiencies. So I don't actually see the good out of it. So I was actually wondering if it actually decreases the mortality, but it seems it does. So
Yeah.
thank you everyone who pointed to the study.
Yes. And so from a statistical point of view, this is what fools us. We, the medicine people see all the bad side effects of surgery. We don't see all the good cases, but they never come to us. So, but there are a lot of complications, and I assume you've seen most of the complications that Anne-Marie mentioned in her wonderful review just now. So it's important to think about all those things. So I'm going to let Dhruv and Travis summarize what they learned from discussing this case. And in the meantime, I'm going to look up the exact reference for the case to write it up in case you want to use it in your teaching.
You first, Dhruv.
All right, yeah. So I guess I'll start. I think the big thing that I learned, because this is one case that I think had actually been teased before, but so I guess I sort of knew the final diagnosis, but I guess going through the process of, okay, if a patient has a Roux-en-Y gastric bypass, what are the complications that you need to look for and be on the lookout for, especially if they come in with this presentation of being altered. And sort of going through the whole process of determining if they have an acidosis. Is it a metabolic versus respiratory acidosis? Is it anion gap versus non-anion gap? Just reviewing that whole process were, I think, the two big takeaways that I had from this case.
I put the link to the article that we wrote up this case in 2013. I think it's a good teaching case for a variety of different reasons. Travis, what do you think the big take-home points are today? And thank y'all for hanging around for me to get back on the internet. That was so kind of everybody.
We were just making jokes about you when you were gone.
I don't blame you at all.
I like the bicarb pearl. I think that was a really a good one. Just kind of translating bicarb in milligrams that we give in a pill versus what you would give in an Arm & Hammer baking soda, and just kind of going over kind of what alarm bell you give for an elevated anion gap, less than 25, but the ones to look out for that can kind of sneak under the radar with the D-lactic acidosis, which is something that I've never seen, but if I have come across it, I've missed it. So now it'll be on my radar, and just the little mechanisms that exist, with the ornithine pathway and valproic acid and the pearls that, Anne-Marie and Fernan shared. So those are all good ones.
So Anne-Marie, you're so good at this. I hope that you will consider doing a schema on altered mental status after Roux-en-Y surgery, because I think that's great. And the albumin time. I'm sorry, Anne-Marie.
I said only if Thiago agrees to help me.
Good. The albumin one is really useful. What I tell the house staff, and I suggest you tell them that if somebody comes in with an anion gap of 18, an anion gap of 18, and they have a normal albumin, they're usually a little ketotic, maybe even have mild lactic acidosis, and you give them some fluids, and the next day it's okay. I don't work those up unless there's something suspicious in the history, and that what this case represented was the thing that was suspicious in this history was the altered mental status and the confusion and the feeling of being drunk. And that's why this one was worth working up. I'm getting ready to work on the podcast version. Next week, we probably will not have unRemarkable Labs because it's the chief residence big end of the year dinner. And so we're going to let them have that dinner to and enjoy it. And we are working on a few more of the unRemarkable radiologies. And then sometime in June, Fernand has a couple of good cases for us, but we'll have more good cases by then because I'll be back on service soon. Actually, I'll be back on service in 11 days. And I'm looking forward to it. I appreciate everybody who participated today. I really enjoyed the group teaching and participation by so many people. I think it was really worthwhile. I think we all learned a lot. So everyone have a wonderful rest of your week. And Anne-Marie, I hope that as the rain comes from the west up towards North Carolina, it's not as brutal as it's been down here.